Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
This is a different kind of talk. It's 3 cases, 2 of which I was involved with here at Harborview, and 1 is a made-up case. And there's a lot of overlap in their presentation, but some differences in what causes them and how to treat them. So I'll start with my disclosures and then disclaimer, and then we'll move right into case number 1. So this patient is a 48-year-old man with HIV who in May of 2016 was diagnosed and had a CD4 count of 47. He started on antiretroviral therapy and rapidly suppressed, but then presented a month later with fatigue, shortness of breath, night sweats, and headaches that have been going on really since he started ART. On presentation, he was pale and ill, febrile, tachycardic, tachypnic, otherwise pretty bland exam. But his hematocrit was 17, his white count was 5, and his platelets were 32. His chest X-ray and head CT were normal. He was treated for sepsis with meropenem, vancomycin, also started on acyclovir and continued on his antiretroviral therapy, and then had a big workup that was largely negative. Blood cultures, urine cultures, acid fast and fungal blood cultures negative, cryptococcal antigen negative, CSF studies that are listed there negative, urine histoantigen negative, serum parvovirus also negative. And these are the results. He has massive splenomegaly with diffuse axillary retroperitoneal and pelvic adenopathy. So that's kind of a juicy finding. So he has a lymph node biopsy that shows HHV-H-associated plasma cell proliferation. And the pathologist said the morphology is not that typical for MCD, but it's likely that this process evolved from multicentric Castleman's disease. So that's the diagnosis that we went with. He was treated with rituximab for 4 doses. He developed KS and bilateral pleural effusions that were treated with liposomal doxorubicin. He was also put on valganciclovir for persistently positive HHV-8 levels. And he responded well, but then was discharged from the hospital, but unexpectedly died months later. No autopsy was done. But I think this was an excellent case of multicentric Castleman's disease. So just to remind everyone what that is, a lymphoproliferative disorder affecting B cells and plasma cells, episodic flares of these inflammatory symptoms, all of which he had, cachexia, edema, adenopathy, organomegaly. It can evolve into B cell lymphomas, and I guess it's no surprise that KS is present in 70% of patients because it is an HHV-8-mediated illness. Laboratory findings are cytopenias, low albumin, hyponatremia, elevated inflammatory markers, and flares almost always have high levels of KSHV or HHV-8. And without treatment, the condition is generally fatal. The diagnosis really rests on pathology, on lymph node biopsy, and it comes in 3 flavors: a plasma cell predominant variant, a hyaline vascular variant, and then a mixed variant of the 2. All pathology does have vascular hyperplasia, and all pathology will show expansion of KSHV or HHV-8 infected B lymphocytes. And to find KS in the same lymph node is very common. So how does this happen? There are several genes that HHV-8 expresses when it's in the lytic phase of infection. Those genes are listed there. And they act through transcriptional factor NF-kappa B to enhance the expression of human IL-6 and a counter-regulatory hormone IL-10, but it's really driven by IL-6. The virus HHV-8 also has a viral homologue of IL-6, the VIL-6, and it's thought that this might play a role in the disease pathogenesis as well, although it's the human IL-6 levels that are dramatically high in people with MCD, much more so than the viral homologue of that cytokine. Treatment is continue antiretroviral therapy, and then anti-CD20 rituximab is given weekly for a month. That targets HHV8 infected cells that express CD20, and it also eliminates B cells that then deprive the HHV8 cells of the cytokine signals that they need to continue doing what they're doing. Chemotherapy is part of the treatment, typically etoposide and or liposomal doxorubicin. There's some older data suggesting that valganciclovir plus high-dose AZT both are phosphorylated in cells that are infected with HHV8 and could kill the cells that way, but the real cornerstones of treatment are rituximab and chemotherapy. And then since the disease is really driven by IL-6, the drug siltuximab, which targets IL-6, or tocilizumab, which targets the IL-6 receptor, have been used and are under investigation for MCD. There's been a recent review published 10 years ago now, 19 studies, over 600 patients, most of whom were infected with HIV. Characteristics of the patients in these studies, 2/3 were on ART, with 40% being suppressed. Median T cell count in people who developed MCD was over 200. Almost all had positive plasma HHV8 levels. And again, no surprise, KS was present in the majority of people. This is a mortal infection with a mortality rate of 25%. Those that are treated with chemotherapy alone die at a rate of 37%, while those who get rituximab with or without chemotherapy do much better, 10% mortality. And anti-IL-6 therapy hasn't been used as much in patients with HIV, mostly in people without HIV. And other outcomes that are observed, progression of KS in 13% of the people, but that's mostly those who got rituximab alone. So that's something to remember, is that rituximab may be a risk factor for the progression of KS. So if people get treated with both rituximab and a chemotherapy, that's much less likely to happen. 47-year-old man with HIV and AIDS with a T cell nadir of 10. He's had a history of KS and MCD. He was treated with 4 cycles of rituximab and Doxil in 2011. He's also had cerebral toxo, and now presents with 3 days of fever, myalgia, headache, fatigue. T cells are over 400. Viral load is just barely detectable. His ART is listed there. He's had similar presentations in 2013 and 2014, and they resolved without specific therapy. And notably, during each of these episodes, his HHV8 levels were elevated. So on exam, he's also ill-appearing, febrile, tachycardic, and hypotensive. He does not have tender adenopathy or organomegaly. He does have KS on his feet. White count 7, hematocrit's 43, platelets are low, LFTs are normal, but his albumin's a little low. And as the first case, his chest X-ray and head CT are normal. So he's admitted to the ICU with a sepsis rule out. He's treated with fluids and antibiotics. He gets a CSF sample taken. The formula is benign, and all of the CSF studies are negative. So what do people think is going on in this case? CRP is dramatically high. His HHV8 level is also high, 1.2 million copies. And his IL-6 level, that's high, by the way. He has HHV8 or KSHV inflammatory cytokine syndrome, or KICS. And KICS is essentially MCD, but it's not MCD. So the pathogenesis is very similar. Lytic expression of HHV8 leads to overexpression of viral IL-6 and other genes that induce the expression of human IL-6. There's also dysregulation of T cells and activation of macrophages and PMNs. There is a working case definition that is listed here in this table. Clinical manifestations divided into symptoms, labs, and radiographic findings that are listed there. You need to have at least 2 of those 3, so symptoms, labs, or radiographic findings. And you have to have number 2, systemic inflammation defined as a CRP greater than 3. You have to have KSHV viral activity, and you have to not have MCD. So have gone through histopathologic examination, and there is not MCD histopath. So just putting these together, MCD we talked about, lymphoproliferative disorder, and we went through the histopathology showing these polyclonal plasmacytoid cells or B cells, high levels of HHV8, high levels of IL-6, generally low HIV viremia, and T cells are usually robust. KICS is essentially MCD, but the histopath is not showing MCD. So high levels of IL-6, high levels of HIV viremia. So these patients, unlike the patient that I just presented here, usually have lots of HIV viremia, and their T cells are usually lower. So these are people that generally have more advanced disease than the patients with MCD, and they present just like MCD, but when you biopsy their nodes, there's no evidence for it. And they have less prominent adenopathy and less prominent or no hepatosplenomegaly. So it's very similar to MCD, but without the pathway. I just put KS-IRIS up here because many patients with both KICS and MCD can have concurrent KS, and so you have to think, is this just a manifestation of their KS, or if they just got started on antiretroviral therapy, could they be having a KS-IRIS syndrome? In that case, KS-HV viremia is typically low, so that's a differentiating factor. And they usually develop KS-IRIS in the setting of recently having started on antiretroviral therapy, and their CD4 counts were low and then are increasing. So overlap for sure, but these are some distinguishing features that can help parse those out. Okay, for treatment and outcomes, there aren't any clear treatment regimens, and generally the same therapies that we use, the therapies that we use for MCD are the same therapies we use for KICS. Rituximab monotherapy works very well, but 1/3 of people who have KICS and are treated with rituximab monotherapy will have a progression of KS. So it's probably true that B cells, and there is some antibody control or ADCC control of KS, then once you eliminate those antibodies, KS can flare. When people are treated with rituximab and liposomal doxorubicin, event-free survival is 82%. And in that case, in this one series, only 1 of 17 patients had progression of their KS when they got both chemo and rituximab. So he is diagnosed with KICS. He's treated with liposomal doxorubicin, rituximab, prednisone, and valganciclovir, and he's better and discharged in 7 days. He got 2 more cycles of liposomal doxil and rituximab as an outpatient, and he's been well and has had no further recurrences. Okay, last case. This one is made up, but see if you can get it. 24-year-old gay man moved to Seattle from southern Indiana, where he worked as a laborer on a free-range chicken farm shoveling manure. He fell ill on the bus ride west to Seattle and arrived at the Harborview Emergency Department with a fever, cough, dyspnea, lower extremity edema, and headache. Physical exam revealed an acutely ill-appearing young man with a blood pressure of 90/60, heart rate of 126, respiratory rate 30, mild meningismus, fine rowels at the lung bases, and a tender left upper quadrant. And his chest X-ray is not normal. I show it to you there. His hemoglobin is 8. His platelet count is 90. His white count is 1.2. He has an HIV test performed, the 4th generation, and the test is positive, but the confirmatory antibody testing is negative. So his HIV RNA is very high, 1.2 million copies. He also has a urinary histoantigen that's strongly positive. So he started on amphotericin, and a week later, he started on bictegravir taf-FTC, but he remains febrile. And now his hemoglobin's worse, his platelets are lower, and his white count is 0.8. What test do you want to do now? You're treating his disseminated histo, and you're treating his primary HIV infection. He has the following test done: a ferritin, 15,000, triglycerides, 350, soluble CD25, which is an IL-2 receptor, is very elevated. And his bone marrow biopsy shows the following. This is a macrophage or a histiocyte that is gobbling up all these little histoplasma. His bone marrow also showed this, which is engulfment of some PMNs by activated macrophages. He is diagnosed with primary HIV, disseminated histoplasma, and hemophagocytic lymphohistiocytosis, or HLH. That's exactly what this gentleman had. Nicely done, everyone. So HLH is upregulated and hyperactive T lymphocytes and macrophages that lead to hematopoietic cell phagocytosis and cytokine release. There are two ways to get it: primary and secondary. Primary are basically genetic disorders of perforin or granule secretion, intracellular trafficking of lysosomes, or signal transduction of T and NK cells that are out of whack. These are diseases that present in childhood, very young childhood. When adults get it, it's almost always secondary to something else. Certain infections, malignancies, or autoimmune disorders can trigger an HLH presentation. So the diagnosis, there's the HLH Society now that has published guidelines on making the diagnosis. And you need 5 of the following 9 things. And you should note that hemophagocytosis, which I think we previously thought was, well, that's the gold standard. If you've got that, then you've got HLH. But that's not necessarily true. You need to have 5 of the following 9 criteria in order to have that diagnosis: fever, splenomegaly, cytopenias, elevated triglycerides or low fibrinogen, hemophagocytosis, low or absent NK cell activity, that's a send-out test, ferritins over 500, soluble CD25, which is the IL-2 receptor, and the latest thing that I was not aware of is elevated CXCL9. I'm not sure what that is. I didn't have time to look it up, but I was too lazy to look it up, but that's one of the 9 criteria. There was a review recently, 81 patients with HIV and HLH, a review of 81 patients from 70 papers. Median age was 40, most were men. Clinical presentation was, not very different from KICS or MCD. The median time from HIV to the diagnosis of HLH was a year. Most people had been on ART at the time of the diagnosis, but not exclusively, and HLH was the presenting symptom that led to the diagnosis of HIV in a third of patients, and 1/3 of these people actually had primary HIV that was the trigger for their HLH. These are just a list of the triggers on the left-hand side, the most common trigger being a variety of viral infections. Number 2 after that was invasive fungal infections, and by far and away the most common disseminated fungal infection is histoplasma that's associated with HLH. This is followed by HIV alone, bacterial infections, iris, acute HIV, and each of them, the different triggers have different prognoses that are listed in the percent cured category there. You can see if you get HLH because of a malignancy, or I think this is on the next slide, or iris, you don't do as well as if you get it from a disseminated fungal infection. The overall mortality from these 81 patients is 40%. 60% received HLH-directed therapy, which is steroids, IVIG, chemotherapy, which is almost exclusively etoposide, anakinra, cyclosporin. And half of the patients who got HLH-directed therapy died. Those with iris or cancer did worse with higher mortalities compared to those with invasive fungal infections. And in general, when the triggering disease was treated, patients did well, or relatively well, whether or not they got HLA-directed therapy. So that seems to be key, identifying the trigger and treating that, and then decide whether or not you want to add on HLH-directed therapy after that. Only 3 patients relapsed who were among those who were cured. Okay, so last slide here, HLA sepsis imposters. These are uncommon inflammatory disorders. HHV8 is associated with MCD and KICS, and other infections and malignancies trigger HLH. The clinical presentation overlaps greatly. MCD and KICS, moderately ill with fevers, sweats, edema, adenopathy, organomegaly, cytopenias, and high HHV8 levels. HLH also has cytopenias, toxic people, phagocytosis, fevers, organomegaly, but a different set of laboratory tests that can help seal that diagnosis. High CD25 levels, ferritins, and CXCL9. Pathogenesis we went through, and the treatment for MCD and KICS is antiretroviral therapy, rituximab, most of the time with liposomal doxorubicin, while HLH, the treatment is treat the trigger, and probably most people will get etoposide and steroids, especially if they're really ill from it. But not everybody needs that. Okay, glad to answer any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.